Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Clinical Impact of Delaying Initiation of Adjuvant Chemotherapy in Breast Cancer Patients by Deborah Gagliato et al. My name is Marco Corleone, and I am co-chair of the International Breast Cancer Study Group and director of the Division of Medical Sinology at the European Institute of Oncology, Milan, Italy. My oncologic specialty is breast cancer. The proper timing of commencement of adjuvant chemotherapy has been studied for decades. There is in fact a biological rationale to start chemotherapy as soon as possible after the removal of the primary tumor. Since the late 70s, there has been evidence that tumor removal as well as surgical trauma might lead to an accelerated growth of micrometastasis and an increased number of circulating tumor cells. In addition, an increased probability of drug resistance in micrometastatic disease in case of delayed administration of chemotherapy has been hypothesized. Retrospective analyses evaluating the role of early start of chemotherapy were published, reporting conflicting results. Studies differed with respect to the patient, disease, and treatment characteristics included, as well as the arbitrarily selected cutoff for the definition of early versus delayed start of therapies. The different results observed are not surprising, considering the retrospective nature of almost all of the reported series and the related potential for bias. On one hand, chemotherapy might have been selectively administered earlier in patients with poor prognostic characteristics. On the other hand, delayed start of chemotherapy might be due to patient-related factors that affect the outcome, such as comorbidities or delayed healing following surgery, which may be indicative of overall poor health status. The issue of timing of adjuvant chemotherapy has not received much recent attention from physicians and patients, and consequently, practice has not changed substantially. The lack of change in the attitude towards timing of adjuvant chemotherapy might be related not only to the above discussed controversial results, but also to the increased request for additional testing or procedures used to decide whether or not to offer adjuvant chemotherapy. In fact, a significant increase in time between surgery and start of first adjuvant treatment has been reported during the last 10 years. Gagliato and colleagues report on outcomes according to timing to initiation of adjuvant chemotherapy of 6,827 patients. Overall, no differences were seen between cohorts starting chemotherapy either 0 to 30 days, 31 to 60 days, or more than 60 days after surgery with respect to overall survival, relapse-free survival, nor distant relapse-free survival. Patients with more advanced stage disease experience worse outcome in terms of relapse-free survival and distant relapse-free survival, stage 2 and 3, and overall survival, stage 3, if chemotherapy started more than 60 days from surgery. Also, patients with triple-negative disease and those with HER2-positive disease treated with trastuzumab had a worse overall survival if chemotherapy started more than 60 days after surgery, while no differences were seen with respect to relapse-free survival or distant relapse-free survival. There are biological explanations for the observed results. It is reasonable to presume that conclusions regarding the magnitude of treatment effects that rely on the overall population of breast cancer patients may not be appropriate for selected breast cancer subtypes. 2/3 of the patients had hormone receptor-positive disease, and there was no indication that timed initiation of chemotherapy for these patients made any difference at all. Smaller subpopulation of patients were identified for whom delays to initiate chemotherapy might be avoided. the magnitude of the benefit of adjuvant chemotherapy might indeed be larger in locally advanced breast cancer, where there is higher probability of presence of micrometastatic disease. Triple-negative breast cancer is characterized by high risk of early relapse and significant response to chemotherapy, irrespective of patient's age. Similarly, the overexpression or amplification of HER2 is associated with poor prognosis and unfavorable prognostic features. Early initiation of targeted anti-HER2 therapies have been shown to be correlated with improved outcome in randomized trial conducted in patients with HER2-positive disease. While Gagliato and colleagues draw attention to the issue of timing of initiation of adjuvant chemotherapy, the results can only be regarded as hypothesis generating, and new data are required before widespread modification of current clinical practice. The influence of the play of chance on the observed results cannot be overlooked, given the multiple subgroup analysis and endpoints considered, and the inconsistency in trends for the three chemotherapy initiation time intervals. Some results suggested that very early initiation, 0 to 30 days, is required, while others highlight that starting 61 days or more might be detrimental. Confounding factors both affecting the delayed chemotherapy start and patient's outcome, in example comorbidities, might be implicated in the results observed. The findings for the triple-negative cohort showing differences with respect to overall survival but no impact of chemotherapy timing on relapse-free survival or distant relapse-free survival raise concerns that at least some of the overall survival differences are due to patient selection. Conclusions relating to HER2-positive disease are also problematic, as differences in outcome according to chemotherapy timing were seen only for the overall survival endpoint for patients who received trastuzumab. The shape of the overall survival curve for the 106 patients who received trastuzumab is striking, with no death within the first 2 years of diagnosis and a very large number of deaths within 2 to 3 years of diagnosis. A review of the cause of death for these patients may reveal that comorbidities, in example cardiac, delaying initiation of anthracycline-containing chemotherapy may be exacerbated by trastuzumab, and that the results shown are not entirely related to delayed administration of chemotherapy. Taking into account this consideration, how should we move forward? A randomized clinical trial is unlikely to be undertaken, considering the problems related to difficulties in recruitment and logistics, as well as ethical issues. The recognition of the heterogeneity of breast cancer recently has led to the concept that tailored adjuvant treatment investigation in specific patient subpopulation through international collaboration is key to improve the outcome of individual patients with early breast cancer. Several ongoing randomized trials focusing on selected breast cancer subtypes might provide further useful information on the value of early start of chemotherapy. Meanwhile, evolving evidence indicates that it is unlikely that early commencement of chemotherapy make a difference for the majority of patients. Although the evidence is weak due to potential biases and inconsistent outcomes, the current report suggests that unnecessary delay in initiation of chemotherapy may be unwise for patients in whom the effect of adjuvant chemotherapy is expected to be significant. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.